Right, good morning everybody. Welcome to the September meeting of the CQC board. The first time we've been able to meet physically since the start of the pandemic. I apologise first of all that we can't yet have members of the public actually join us. We are obviously socially distancing in this room. In fact, in these rooms, I mean, we've opened up a number of meeting rooms to get us all in, and it just isn't possible to have members of the public as well. But of course, we will continue to take questions from members of the public and deal with them as we were doing when we were having to operate via Teams. We have an apology from Belinda Black, who unfortunately is unable to be with us today. I want to welcome Paul Kirby. Paul, you've been at our meetings before. Paul is the chair of the Disability Equality Network. I also want to welcome Tyson Heppel to his first board meeting. Unfortunately, Tyson got pinged and is having to self-isolate until getting a negative PCR test. So Tyson is joining us remotely. But Tyson, it's great to have you on board. So that's by way of introduction. Are there any interests anybody needs to declare that aren't already known? Excellent, that's good. That takes us to the minutes of the 21st July meeting. Are they a true and accurate record of everything we discussed?
Yes, thank you.
Yep, thank you. So we'll take those as approved. Miraculously, there's nothing on the action log. I haven't been notified of any matters arising, but is there any matter arising anybody needs to raise? Good, in which case, Ian, will come straight to your executive team report, please.
Thank you very much, Peter, and good morning, everybody. So if I look at the Chief Exec's report, I gave evidence to the Health and Care Bill Committee recently. Our focus as CQC remains our future role in providing the public and Parliament with oversight of integrated care systems, local authority Care Act duties, and of course the work that we will do to integrate hospital food standards into our work. We will be submitting follow-on written evidence to the Bill Committee, and we have also talked to various parliamentarians about our perspective on various aspects of the Care Bill, in addition to the verbal evidence that I gave. In terms of stakeholder contact, I had some good positive meetings with Amanda Pritchard, who is the new Chief Executive of NHS England, and Peter and I also met the Right Honourable Sajid Javid, again in both cases discussing our role, particularly around how the health and care system recovers from the pandemic and what we can do to assist, whilst at the same time, of course, assuring the quality and safety of the health and care system as the services recover. I also want to place before the board and seek the board's approval for the Responsible Officer Annual Report. This is something that we do because we employ a number of doctors. The appendix to the report confirms that we have carried out the necessary work to revalidate our employed doctors and that they remain fit to practice. There's little change to the report this year from last year. NHS England have helpfully changed the rules slightly this year to make it a little easier post-pandemic in terms of revalidation. I'd also like to place on record my thanks to Nigel Aitchison, who is one of our Deputy Chief Inspectors in Ted's team, who has done the work to make sure that revalidation takes place. It's important work and it takes a fair amount of time to do, but a big thank you to Nigel on behalf of the board. So I'd just like to seek, Peter, the board's approval for the information which is contained within the appendix to my report so we can revalidate our doctors. Thank you.
Mark.
Thanks, Chairman. Ian, I wanted to also note the good job that Nigel does, and I'm happy to approve, but could I just make two comments on it? Firstly, that we've had no peer review of appraisal and revalidation since 2016. So I wonder whether Nigel would perhaps comment on that back to us, and whether that's something that we should review. And secondly, the employment checks on SOADs and SPAs are made by the Flexible Working Office, and I just wondered whether that might be an item of interest for the RGC, but clearly that's Mark's responsibility, but it seems to me that that's very much tied up with this report, and is perhaps worthy of further review.
I'm happy to take both of those things away and come back. Thank you.
Okay, so we're happy to approve? Yes. Good. Right. Thank you, Ian.
And then hand over to Kate.
Thank you. Good morning, Board. I'm going to give you an update today on our work around close cultures. So you'll all recall that we are currently piloting a new quality of life tool that we've developed with Warwick University, which is about enabling us to really understand the experiences of people with learning disabilities and autistic people and the care that they receive. So this is about looking at what the care plan tells us is happening and then really seeing it from the person's perspective about whether that is their experiences of the care that they are receiving. We started this pilot in hospital settings and we are continuing to do that. We've now rolled it out to adult social care settings, and we are finding it as an effective tool for identifying the quality of care being delivered. We've got an evaluation underway, and we'll be sharing that with our expert advisory group in September. We've also been busily having extensive engagement about what should our role be around surveillance, and want to say a big thank you to many people who use services, stakeholders, experts in the field for engaging in those conversations and really helping us form a view about where we go next with that. And I look forward to coming back to board at a later date to provide that update to you. And then finally, we've been prototyping how we can use our intelligence indicators of what may constitute a closed culture to help inform our inspectors about where they should be targeting their efforts. And that will be being rolled out shortly. So that's all I intended to say. Thank you, Peter.
Thanks, Kate. Ted.
Thank you, Peter. Just to add to the written report, the inspection teams in hospitals have been very busy over the summer, as you can see, and they have a busy programme going into the autumn, focusing on risk-based inspections and targeting all the areas of risks that we've identified through our monitoring arrangements. And this process is going well. It means we are focused on those areas of risk. And I suppose one of the things that I'd like to come back to is how can we demonstrate improvement in those services have improved. In some instances, I've mentioned this to the board report, we'll be publishing reports very soon around trusts that have actually made quite significant improvements in the quality of care despite managing the pandemic. And I think this is a great tribute to those organisations. And when we publish those reports, I look forward to celebrating the success of colleagues who've been working under pressure, but also delivering for their patients. I just also want to highlight the pressures on urgent emergency care. The board, remember I mentioned this at previous meetings. Those pressures have been continuing over the summer period, and they continue into the autumn. We had a workshop with Chief Executives, Chief Operating Officers of acute and ambulance trusts last week, and they are describing a situation that really is unprecedented in terms of the pressures on urgent emergency care, greater than they've seen in previous winters. And of course, we are at the beginning of the winter virus season, so I think everyone is concerned about what the next few months will bring. I'm glad to say that all parts of the system are really working together well to try and support services going forward, and we will continue to work very closely with other parts of the system, such as NHS England and the providers themselves, to support services going forward. The workshop, I think, was very useful. It was built around our patient first guidance, which the board is aware of, which I think colleagues have found very helpful in focusing on safety of patients primarily in the pressurised urgent emergency care system. The particular concern that we and NHS England and providers have are the extended ambulance handover delays, and we're working with the different parts of the system to provide guidance and support from a regulatory point of view to help manage that problem as safely as possible. Can I also mention the maternity report that we published yesterday, which colleagues will be aware of? I won't reiterate the issues that are raised in the maternity report, but this is based on recent inspections, and it shows that many of the issues that we've identified in the past are still present in those services we've inspected. But I think to counterbalance that, there's a real sense of acceptance of the problems across the whole system and a real determination to do something about it. So while the issues in maternity are still to be resolved, I am very optimistic we've got the right coalition of support to drive this forward over the next few months and years. So that's all my report. Peter, I'll hand back to you.
Thank you, Ted. If nobody wants to come in, Rosie, we'll go to you.
Thank you very much, Peter. And just a couple of areas to report from myself. One is that I joined the Chief Inspector of Ofsted at the Lords Public Sector Committee to talk about child vulnerability. And it was an opportunity to talk about the importance of all parts of the system working together to see how we can improve outcomes for children across health, social care, education, and the wider system as well. Just to reiterate Ted's points, we are continuing to see unprecedented pressure in primary care as well, huge demand on the system, and we have held several listening events with colleagues in primary care and heard what they are experiencing at the moment. And can I just say thank you to all colleagues working across the system who are working incredibly hard at the moment to deal with that pressure. Finally, I just want to mention the very sad attacks that we heard about on a practice in Manchester last week. Sadly, we are hearing about increasing abuse to primary care practices. Sadly, there was some very serious injuries as a result of an attack in Manchester last week, and subsequently someone has been charged with the assault. But I just want to take this opportunity to say that that abuse of any form to health and care professionals is completely unacceptable, and we need to make sure that we collectively across the system are making sure that that message is out there, because people are working very hard under very difficult circumstances, and any kind of abuse is unacceptable. People need to be treated with respect. Thank you.
Thank you very much, Rosie. And I mean, I just on the points that both you and Ted have made. I mean, first, I absolutely reiterate the pressure that everybody's under, and actually also in social care as well, Kate. So this is a really difficult period. And secondly, I do hope that the media and other commentators will say what you've just said. It is unacceptable, whether it's abuse, physical or verbal, whether it's in general practice or emergency departments or anywhere else. And I think as a board we should absolutely deplore any action like that. So let's now have an experiment and invite Tyson to give his report remotely. Tyson. This could be an experiment that's going to fail. It has failed. So in the best example of television and radio people who then find that the person they were about to interview is not on the line, will have to move on, and hopefully maybe come back to Tyson later on. Mark, let's go to you, please.
Pleased to report that we have no significant information or cybersecurity incidents in the last month.
I always like to hear that report from you, so thank you. Chris.
Just to give a quick update on some of our engagement and publications that have happened in the last month. Firstly, we've had really good engagement, as Ian mentioned, from the government on the passage of the bill, but also from MPs involved in the development of the health and social care bill. In particular, CQC's position as an independent voice of assurance has been an important feature of what MPs from all sides of the House have said that they value in the legislation as it moves forward. I just want to build on something that Ted said earlier around the report we published this week on maternity. Two things that were of note there. both the providers of service and the public groups recognised the value and saw the report as an ability to move forward on some of the key issues around inter-team relationships, about training and support, and also about how women are engaged with through the process, through pregnancy and through their postnatal period. And I think it's a testament to the way in which the report was carried out and the way in which we gathered the voice of every party, that everybody can see their voice reflected in that. And I'm really delighted to say that James Titken, who's a long time been an advocate for change in this area, is supporting us in our journey to move forward in this. I think we're delighted at the response to this report, but obviously that is only part of what we want to do moving forward. We want to really encourage the change that we've begun to see across all services. Just a note for the board that we've published the Inpatient Survey. This is part of the information that we use to guide our thinking around people's experience of care for reports like State of Care. So these are important elements, and they build together to give a complete picture of people's experience of care over the last 12 months. I also want to talk a bit about a report that has been close to colleagues' heart in the organisation for a long time. The Home for Good report was designed to show that community support for people with learning disabilities and or autistic people is complex, but it is possible. And I think what the report does, it highlighted exactly how people can be supported to live well in a local community and how the services can combine to give people a better quality of life. And again, it's been brought about by the work we've worked with providers, we've worked with people who use services and their families, and I think it's a testament again to the team, the cross-functional team that worked on the report, that we have made it clear that these type of services are not only possible but desirable. They're not only value for money, but in many respects they provide much better value for money than the services that they replace. We know there is some way to go in this. We know there are still some services out there that don't meet these important criteria, but this is for us an important part in that process to make it clear to all people who operate in this area that these are the services that we think are important moving forward. I just want to commend colleagues to look at the report if they haven't done so already, and look at the conversations that we're having as a result of it.
Thank you, Chris. Robert.
Sorry, I actually had a question for Kate, but we skated past that quite quickly, so I apologise for not waving frantically enough. The question really I have is about staffing and care homes, and perhaps in particular what effect, if any, the new rules about vaccination are having on that. But also there is obviously the wider problem that was well publicised in relation to staffing, and I just wonder whether your inspectorate are yet finding that some providers are getting into almost an impossible position, or whether that's not the case.
Thank you, Robert. So the question of workforce comes up on all of our inspections. So do the providers have the staff with the right skills and right values to deliver high quality care? Providers are reporting nationally and to us about their concerns about the impact of vaccination as a condition of deployment that will come into force on the 11th of November, with various different figures being mentioned about the numbers of staff who won't have their 2 vaccines done within the time frame. We've been really clear about our approach to this. So obviously the government has changed our regulations so that we will be enforcing against this. We're really clear that we will take a proportionate approach. We will look at how service is led in the round, but our expectation is staff do have the vaccinations to enable them to provide safe care. We're seeing a multi-layered issue around workforce. So we've got the issue of vaccinations, we've got the issue of tourism really booming at the moment, and staff leaving our sector, social care sector, to go into tourism, and then we've got the implications of the EU exit as well. So all of that in the pot means that workforce continues to be a big area of concern for us within adult social care, and that's set in a context of, prior to the pandemic, 112,000 vacancies and turnover rates of about 37%. What I'm really keen to do is that we continue to look at it through the lens of what does the workforce issue mean in terms of the quality of care being delivered, and we will continue to capture that when we go out on individual inspections, but it will also inform things such as our state of care report that we will be publishing in the next month as well.
Thanks, Robert. And given the size of the room, if anybody wants to come in at any time and I haven't noticed, do shout, wave your arms, do something. Stephen.
Thank you, Peter. I'm not sure whether this is a Rosie question or a Ted question, but are you picking up concerns from your sectors about long COVID? You've both described the pressures that your sectors are under, and they are enormous and they are real. Is long COVID going to add to all of that, and are we getting any sort of stable understanding? Well, what is it? What are the what's associated with it? What is its duration? What are sensible approaches to dealing with it? Is this bubbling up as a concern in your sectors?
Stephen, it is a concern, I know, and services are being set up to support people who have evidence of long COVID, and increasing work is focusing on that. I don't think we know at this stage the size of the issue, because one of the issues is how long do the symptoms last? Is it a few months or is it longer? And I think it is variable in different patients as yet. So our understanding of the condition is developing. So the long-term burden to the system, I think, is not understood fully, but I know people are focusing on this and recognising it. But this is an added burden on top of the pressures that are already there. And the pressures, as I say in my report, are not just COVID related. The pandemic seems to have triggered patterns of behaviour or patterns of disease that are beyond COVID, that are creating extra burdens for the system as well. And long COVID plays into that.
Can I just add, it's certainly a feature. At the moment it's difficult to quantify, and we don't have the data to quantify it, but it's certainly a feature that we're seeing in primary care as well, and GPs are reporting that they are seeing increasing patients with long COVID, which is having an impact as well, both clearly on the patients but also on the demand.
Thank you both. Sally.
Thank you, Peter. It was just a quick question for Rosie, following up what you said about GP access before. So whilst I absolutely deplore the abuse that GPs would be under, there's a real problem, isn't there, with access to primary care? And I suppose different patients need different types of appointments to be available, don't they? We need to treat particularly vulnerable people who might not be able to attend appointments online or understand them, to offer a mixture. And I know from my own local clinical commissioning group, they have issued a advice that says no face-to-face appointments unless absolutely necessary. And it must be really hard for GP practices to be able to differentiate the service that they offer, or the type of service they offer to different patients, whilst they're under so much pressure and whilst they might be told that this is the way they ought to operate. So whilst that isn't our role to mandate how GPs offer access, is there anything that we can do from CQC, both in terms of support and guidance, I suppose?
Yes, certainly, and this is a discussion we're having a lot at the moment with our stakeholders. And just to be clear, I think it's really important that people get the access that meets their needs, that's safe for them, and that could be a variety of mechanisms. For some people, a face-to-face appointment is right. For some people, a telephone appointment will perfectly well meet their needs, and telephone consultation and digital methods of consultation have been used for many years prior to the pandemic. They're not new methods of consulting, and certainly in out of hours and 111 they are being used very regularly as well. I think it is important. We are seeing increasing inquiries about access into the CQC from patients who are unable to access services. We are following those up with the individual practices. I think we also have to recognise there are a lot of patients, and it was seen in the patient survey, that are actually satisfied with the access that they're getting, and the patient survey did confirm that. I think what we need to also consider is how we make sure people are kept safe as they're accessing services, and we need to think about infection prevention control and making sure that practices undertake a good risk assessment to make sure that patients coming into their waiting room are not at increased risk of contracting COVID and other illnesses by the social distancing arrangements in their waiting room. So it's a complex issue which we're working through at the moment. It's very important that people do get access. I think some of the access issues that we're seeing are because there's a huge backlog of work that isn't quite as easy to quantify in primary care as it is in secondary care. We know the waiting lists are huge in secondary care. We know there's backlogs in primary care as well, and that's having an impact on the demand. And there's no doubt there's enormous demand, both related to that, related to ongoing COVID issues, a whole range of different things that are driving demand, as well as the increasing in complexity and the changing demographics that we're seeing that predate COVID that we knew were increasing demand in primary care. So it's a complex issue. We are working with stakeholders very closely because it's very important that people get the care that they need in the right place, in the right mechanism, and that's safe care.
Great. And I can now... Oh, sorry, go on, Jora.
Just a left field question, Rosie. With these technologies like Zoom and Teams and having calls there, sometimes the recording's on and that data is stored outside of UK and sometimes outside of Europe because it's cloud. Are there any guidance on that privacy of data? Are there any areas that we could advise on that?
Yes, and certainly we look at information governance as part of our inspection protocols and look at what practices are doing to make sure that information is kept safe. And there's a whole variety of new systems that are being used in primary care to enable digital mechanisms to aid consultations that have that information governance fully thought through. So it is something we look at and we do have guidance around.
So I was going to say to the board that had we been able to connect Tyson into the conversation, he would have said that he had nothing to add to the written report, so that's fine. And I think that concludes the Executive Director's report. So I think we can move on, Kirsty, to the quarterly update.
We can, but I'm going to hand straight over to Chris, who's going to take us through this piece.
Chris.
Thank you, Kirsty. So quarterly update, including performance for July. So this is the last report we'll receive against the old business plan. So going forward from next month, there will be performance against our new business plan, just for board to note. So I'll run through a few areas and then open it up for comment and discussion from board. So in terms of registration, and I'll give reference to diligent page numbers as we go through just to help board. So this is page 33. So there's been good progress of late. We've seen an 18% reduction in the volume of registrations in the system. In terms of average days to process, which is our KPI, simples at 26.8, complex 127.8. Both are improving trends, but it's worth noting that this KPI will fluctuate until we've moved historical applications through the system. In terms of safeguarding, which is the following page 34, performance for safeguarding alerts is 94% and concerns 97%, both against a target of 95%. Current data shows the alerts KPI is back where it needs to be, and assurance reviews being carried out of all records that are outside of the KPI to make sure we are comfortable with those, and it's a recording issue. On whistleblowing, which is page 35, the following page, we continue to see an increase in whistleblowing. There's a 56% increase from this point last year. In terms of measures, we brought in a new measure in April to record our action within 5 days. At the end of July, we recorded our initial mitigation within 5 days in 77% of cases against a target of 95%. This is an improving trend. We had a sluggish start to the year, it's probably fair to say, and we've undertaken a review of all cases, as with the safeguarding, outside of that target to make sure that we had taken all the action we needed to do, which we found there's no concerns with that, but highlighted areas of additional training and communication needed. As I say, the current trend of that is showing a stark improvement. In terms of regulatory action, so page 36 in the pack, you'll see that 55% of our inspections were triggered by risk. Were in response to information of concern we've received, demonstrating how valuable that information is. It's a huge proportion. The following slide shows a profile of inspections, and it's currently missing a legend, so apologies for that. So the orange is risk-based inspections. The blue is non-risk-based inspections. So you can see the volume of activity we've been undertaking in terms of our actual inspection delivery. And you can also see that we've recorded 11% of on-site inspections have included time out of hours, which is a high proportion. In enforcement, 94% of urgent enforcement action was served within 3 days, which you see on page 38. And finally, or last couple of areas, HR. So this is page 42 to 46, and another apology from me here in terms of the size of the font and some of the blurriness of the images. It's probably fair to say we did try and upload a revised version, but if you've annotated the pack, you would have lost that. So we've had to unfortunately leave it as is, and we'll amend that for next time. So apologies if it's hard to read. Turnover is stable at 9.3%, which is down from 10.6% last year. Sickness currently at 3.4%, with stress, anxiety remaining as the top reason. Black, Asian and minority ethnic colleagues make up 13.7% of our workforce, with 9.7% in senior roles, 9.7%. And disabled colleagues make up 8.1% of our workforce, just some of the stats coming out of that pack. In terms of our money, just to end with it, at the end of July, we were 7.8 million underspent year to date, which is forecast to increase to 12.5 million. On our capital budget, we're underspent by 2.1 million, but we are anticipating being on budget for the year. Our budget assumed an uplift in activity. We're not seeing this as we adapt to our ways of working. For example, significantly reduced travel costs this year. We're looking at what plans we can accelerate forward into the year, but alongside that, we're also looking at what our future budget requirements are, what this means for fees, and we'll bring that back to the board in due course. So that was it from me, Peter. Thank you.
Thank you, Chris. Ali, was it you or Kate? Sorry, sorry, you were actually waving for yourself, were you? Sorry, Kate.
Thank you. Thanks, Peter. So just a couple of extra bits to add, if I may, on Chris's update. So the whistleblowing, so the ask we introduced of our staff to tell us the immediate mitigation they're putting in place when a whistleblowing came in was a new way of how we expect them to record. The report was saying 77%, that's the year-to-date statistic. Just to give board the most up-to-date figures, because this is such an important issue, in August it was 85%, and we're on track for hitting 90% in September, and it's 92% in adult social care. So just wanted to say that it was a new measure we introduced. We've done the deep dive to make sure we took the right regulatory operational action, but that number is absolutely headed in the right direction. And then I just wanted to flag, Chris mentioned the 11% of inspection activity having an out-of-hours component. This is critical, and this is critical. It came out of our learning from Glynis Murphy. It came out of our learning from how we can get better at spotting close cultures. And actually being in a service when people are getting up in the morning, when handover is happening at night time of a weekend is really important. And I know Belinda, one of our colleagues, has asked a question before about that number. So we clarify what constitutes about an out-of-hours visit. We built it into our system now, so inspectors have a way of recording it, and the fact we can now capture it and report that it's up to 11%, I think, is really positive, and I'd like to see that number continue to go up as well. So just wanted to really highlight that stat about the amount of activity that's happening out of hours. Thank you.
Thanks, Kate. Stephen.
Thank you, Peter. Chris, could I just ask a bit more about page 44 in the pack, which is the one about staff sickness, and that apparently very sharp rise in the last reported month. Do we know what that's about? And if, as in the right-hand chart, the vast majority is anxiety, stress, depression, those types of sort of mental health issues. Is that associated with sort of return to across the threshold inspections and back to the office, or what is that about? Do we know?
Kirsty.
Thanks. So we usually start to see a spike in sickness at this time of year as flu and cough and season starts to come in. So I think if you look at that across it on a 12-month, I can't see what the date on that one is, but I think as people are starting to travel more, we'll see more of that happening, because obviously people have been stuck at home and isolating for a while and not mixing. I think the sickness and the stress and anxiety one we monitor very carefully, and everyone who is off with that has a programme and has a stress assessment to make sure that we're keeping a close eye on that and making sure that we're doing the right things to get people back. So I think I'm not too worried about that if you look at our sort of longer term trends over time.
Yeah, and the scale of the graph makes the increase look a bit more dramatic than it actually is. Well, it's a good point, though. Anybody? Yeah, Robert.
Thank you. Just a similar sort of question about employee feedback and diversity, and I'm page 14 maybe, and it was the word cloud, which is reasons for people leaving, and I wondered, a career progression is the first one. That's obviously positive. Higher salary benefits, probably not much we can do about it. But the next one down is well-being, and is that, as the size of the word would suggest, really quite a small number, or is that something we ought to be worried about?
Shall I answer that again? Yep. So I think we keep a track of that. I think our if you look at our turnover rates, it is quite low. So I think it does look like a big word, but actually it's not that many people. I think we've got lots of work we do around our well-being and maintaining that. But people have had a very difficult 18 months. We've had a lot of, particularly our frontline inspectors, have been working very, very hard and are looking at whether there are other alternatives available to them that may give them a slightly better work-life balance. Having said that, I think the numbers are relatively small, so I don't think it's anything too much to worry about.
Thank you.
Ian.
And just to add to that, I think it's also true to say that there's enormous variability between different directorates. I think some directorates have an age profile which is profoundly different to other directorates. So things like career progression, as a for example, will be stronger in some directorates than others, and equally the wellbeing issue is quite variable. So I think in terms of what we do about this, the answer is that it's reviewed on a monthly basis at directorate level against the specific issues in those different directorates. Thank you.
Mark.
Thank you, Chairman. And Chris, thanks for the data. I'm also looking at the chart, employee feedback and diversity, your chart 14. I think I'm seeing from that starters by ethnicity are higher than the labour market and higher than our CQC workforce mix, which is good. But it's slightly lower than it was in the previous report, which was back in May. Leavers are also higher, so that's not so good. And that's why we're looking at this data. And over time, I think we have the opportunity to access trends and consider our actions. So that's why I think this chart is rich with information, and thank you for providing it. Starters by disability are lower than the market and lower than our workforce mix, and leavers higher than CQC. But I think we recognize there's a bit of a reporting issue in terms of self-reporting on disability. But that's again an opportunity for us to review that and to react accordingly. I have to say I do hope that we can also look at promotions and transfers and secondments by ethnicity and disability going forward. I just commend the exec team for these charts, because it does give us this opportunity for us to look at some of the granular detail instead of those headline numbers on turnover and recruitment. So thank you.
And I think, Mark, we should commend you, because I think it was you who very much help direct us in this way. So, and it is good data. You're absolutely right. Sally.
Thank you. Mark's touched on one of the points I wanted to make, which was that we have a significantly lower percentage of colleagues who declare a disability than in the general population. And I wanted to ask, perhaps not for now, is whether it's simply a factual level of staff who have a disability, or whether it is about declaration or choosing not to. And I think there's an important distinction, but we need to understand what that is. And then just a couple of things on turnover and leavers. We have quite a low turnover, as Kirsty's explained, but it's nearly double in staff who've been with us for less than 2 years. And I wonder whether there's anything more that we need to investigate as to why those people are leaving. It might be that they've just joined during a particularly difficult period, or it might be that there are other reasons, and I think it's worth looking at that, because only 55% of our staff who leave have an exit interview. So there's a significant amount of data that we don't have as to why those people are leaving, and I wondered whether that might change the word cloud a bit. So I don't necessarily need answers today. I think it's just something to go away and think about in terms of the data that we report back.
So, Mark, why don't you start answering?
I can come in on the first question, Sally, if that's okay. So we know that the self-reporting around disability data is not where we need it to be. So we've signed up to the Workforce Disability Equality Standards. We know as one of the actions that we have as part of that is to attempt to improve that, and we have a campaign launching shortly, which Paul has done the video for, which will help hopefully with improving colleagues' reporting around disabilities.
And on your second point, I mean, I recall probably about 3 years ago, we had a much higher proportion of people leaving in the first 12 to 18 months they were with us, and a really quite considerable amount of work was done to improve both the interview process, so people knew what they were letting themselves in for. And being a home-based inspector doesn't suit everybody, and we had a lot of people who thought it was great and turned out it wasn't. And so the number is actually much lower than it was, but it might be something we need to keep looking at, because it's obviously very wasteful to have people only for a short time. Kirsty.
I was just going to say as well is that we've got quite a lot of people that we employ on fixed term contracts for 1 to 2 years, so we would expect them to go after 2 years. So that will be included in this data as well.
Yeah, good point. Anything else from anybody, or are we happy to move on? Great, thank you, Chris. Kirsty, I think this time it really is you that's going to speak.
Thank you, Peter. So in terms of our change and people update, I will do the change update first, then pause if there's any questions, and then there's a few extra people bits just to update people on. So in terms of our change update, over the last few months, we have been focused on really ensuring that our portfolio has really strong alignment with our strategy, and we can really track the benefits of the change work to how we are realising our strategy. And what we've been doing is rearranging our portfolio around 3 core pillars for delivery. These are a regulatory framework, which is our sort of policy framework. The other one is our regulatory services, which is looking at our sort of systems and processes and ways of working. And then the other pillar is our organisational design and development, which is looking at how we organise ourselves, the skills, the capabilities we need to ensure that we're fit for the future as an organisation. We've also been focused quite heavily on our delivery planning, and really looking at how we can take this huge area of work and break it down into deliverable chunks of work. And what we've done is broken the work into 4 key stages in order to make sure that we can deliver in a logical way, where we're starting to build capacity and capability on an iterative basis. The first one of these chunks we're looking to deliver at the end of this financial year. And that one will enable us to develop the foundations for us to become an insight-driven organisation with a strong data quality, and will enable us to test in shadow format our new place-based working end-to-end, so taking us from registration right through to publication of our inspection findings. We'll also in this period pilot our regulatory leadership and professional lead roles, so that our chief inspectors can really start to influence and shape policy and practice across all the sectors as we move through our transformation agenda. As a portfolio as a whole, we've made some really good progress over the last few months in terms of building capability. In terms of the regulatory framework, we now have been focused on developing our single quality framework, which we can apply across the full lengths of our services, regulatory services, starting with registration and taking us through to publishing that rating. The team are now moving on to focus on designing our next stage of our regulatory model, including setting our approach to systems regulation, local authority assurance, and any other aspects of the bill, including incorporating people's experiences into how we assess quality. In terms of our organisational design and development pillar, that has been focused over the last months on ensuring we have the skills, the capability, the culture and the structure to deliver on our new strategy, and has been particularly focused on developing our new hub and local networks approach so that we can better coordinate regulatory activity on a place base. As part of that work, we've been engaging extensively with our colleagues to ensure that we're able to harness their knowledge and expertise and use that to inform our detailed design and thinking. In terms of our regulatory services work, we've been building systems and processes and technology to support our new ways of working, including transforming our data and insight, and also looking at our new regulatory platforms. The transforming on data insight work is on track to deliver our foundational capability that will really support us to become that insight-driven organisation we have our ambition to be. And we've also made really good progress with our regulatory platform in terms of building our underpinning architecture and our digital processes and new systems which are going to support our new ways of working in the future. In terms of so that's what I want to say about our change function. I don't know if anyone's got any questions, otherwise I'll move on to our people function.
I should go quickly before anybody thinks of a question.
All right, I will. So in terms of our people work, over the last quarter, we've been focused on developing our talent and looking at how we can start to grow, build capability for the future. We've completed our senior leadership talent review and are now looking at developing our talent lower down the organisation, and particularly looking at how we can bring forward our work on our level 3 and level 5 management apprenticeships. I'm really pleased to say that we have, in terms of the applications for those apprenticeships, we've had a good number of applications from our black and ethnic minority and disabled colleagues, and all of those who applied have been successful in getting a place on their first choice, which is really, really positive. We've also conducted our people survey, this time focused on wellbeing, and we'll come back to that later on in this agenda. In terms of our diversity and inclusion work stream, we have been running a programme of reverse mentoring where we've had our very senior leaders in the organisation matched up with more junior colleagues to have a really good and honest discussion about what it feels like to be a black and ethnic minority, both working in CQC but also wider in terms of their lived experience. Those have been very powerful experiences, and certainly I can attest to that. But we're now evaluating that programme to see what we want to do in terms of rolling that out wider, and also considering whether we want to do something similar for disabled colleagues as well. We're also focused on building our line management capability, particularly as we move through transformation, and making sure that we have the skills in place to really so that our colleagues feel able to lead their transformation within their teams and feel supported to have those conversations as we move through the implementation of our transformation plan. We've developed a comprehensive suite of training and programs which we've labelled the Successful Manager, which are a series of modules which are going to support managers through this. Our intelligence and data colleagues, or the digital colleagues, have been the first cohort through, and have reported that this has been very helpful, particularly in managing the change that particular team are going through at the moment. That's all from me. Thank you, Peter.
Thank you very much, Kirsty. Gosh, right. Well, in that case, Let's move on. But great report, thank you. And as always, a lot of good information in there for the board. So, Chris, I think we come to you and the Insight report.
Yes, so this Insight report focuses on some work we've been doing to understand how NHS hospitals in particular that have been affected by COVID are beginning to recover. So we did a number of in-depth pieces of work looking at 73 trusts and what they were doing to manage the post of the first waves of COVID. There were three issues, I guess, that emerged from that work. I just want to quickly touch on each three before inviting questions. The first one was about waiting lists. Now, it's clear that the media will report an increase in waiting lists. And I think one of the conversations with, many conversations with the trust focused on how people can, as one organisation described it, wait well. And some examples of that are cancer care coordinators that act as advocates for patients who may otherwise find it difficult to navigate different parts of the system and provide some of the support, the ancillary support between bouts of activity. If there are elective wait increase times, how patients can be involved in support groups and therapies that are therapeutic while people are waiting for elective surgery. There's also an issue about identifying and prioritising deterioration in patients. So how do you keep a handle on people that are waiting and are deteriorating so that you can minimise the risk of harm? And in some respects, using technology as a solution, so home testing, remote monitoring, applications that can support the information access to advice and correspondence. It's fair to say that trusts were cautious about all of these, but I think they all play an important part, and we should be curious about their impact, both in the short term and the long term. But none of them were a panacea, but all of them helped in how we can encourage organisations to think about how people are supported during a wait. The other more obvious area is increasing capacity, and indeed some of the organisations were focused on how they de-escalate intensive care as a way of improving access to capacity more generally. Trust talked about ring fencing of beds for elective procedures, and some talked about offering mutual support and aid, sharing capacity between trusts in a way that you might expect an ICS to perform that role in the coming months. But this isn't just about space, physical space, this is also about people. And there's a really important tension between creating the physical capacity, running at 7 days, and having the staff and the support to be able to make that possible. Which brings me on to my third point, which is the ideas of collaboration. And many of the best examples of how COVID is being managed were not just about the NHS organisation, but about their relationship with primary care, with community care, with adult social care, and actually with the community and voluntary sector organisations in their local area. So many talked about the challenges of dealing with groups that are engaged in trying to support people between elective surgery and actually using some of the resource, particularly of the third sector, to provide some of that support. It is fair to say that there isn't, none of this offers a panacea, but all of it offers an opportunity for organisations to think about what they can do and how they can work with partnerships with others. An important point that was raised time and time again was how to mitigate increasing health inequalities at a time when the backlog of care is so great. And I think the organisations talked about the role of third sector organisations locally in providing an early warning of issues and problems, and using them as a central part of how they manage to recover from COVID. We think it's an important report in that it gives some insight into what different organisations are doing, and I think organisationally it's important that we continue to be curious about how organisations are managing during this time, and we look to celebrate some of the good practice as well as guiding other organisations towards things that they need to do differently. The outcome of this will obviously feature in State of Care this year as well. Happy to take questions.
Great, thank you, Chris. Rosie.
Thank you, Peter, and thank you, Chris. A great report and great to see the innovation that's happening. I just wanted to highlight the importance of local systems working together to work through these end-to-end pathways for patients. It's great to see these new innovations in secondary care. What's so important is that that's thought through and worked through with primary care in conjunction and with all parts of the system. Where this works well, it's where we've had clinicians from all parts of the system sitting down to work out those pathways. Where it's not working well is where new parts, new innovations have been implemented in certain systems, in certain parts, and the implication and impact on other parts of the system has not been identified. I'd also just like to mention what I said earlier, in that I think it's really important that we look at the digital and the remote consultations across all sectors and understand what is safe as we're doing, and the conversations are happening in primary care. It's really important that we look at this across all of the different parts of the system and make sure that we are consistent in our messages, that people need a range of access that meets their needs and is safe for their current clinical condition.
Ted.
Yes, thank you, Peter, and thank you, Chris, for the work that's gone into this report. I think it's a really very valuable report. You'll remember, board members, that we discussed our concerns about these very issues earlier in the year when the size of the backlog of planned care became apparent. How could we make sure that even if care could not be delivered as rapidly as we'd like, the patients were receiving good interim care in the meantime and being supported, and the right priorities were put in place. And I think certainly the work I've done with Trust, talking to Trust, but also the work that Chris has reported in this report shows that Trusts are really focused on trying to manage the backlog of activity as well as they can within their capacity. But remember, the workforce has been stretched during the pandemic, so inevitably they have tensions about the workforce. They have tensions about physical capacity, because they're still got infection prevention and control measures in place, which limits the physical capacity. And as I discussed earlier on in this meeting, the pressures on emergency care will inevitably have some impact on the ability for Trust to complete planned care. And when we talk about needing a new model for emergency care, I think one of the elements of that model is how can that model protect planned care, so every time you get a surge in emergency care, that doesn't have an effect on planned waiting lists. And I think that is something we need to explore going forward into the development of integrated care systems, as Rosie's talking about.
Ted, I was going to ask either you or Chris. There's some really great examples of different initiatives, and I just wondered how we were making sure that this report basically is shared. Obviously not everything will apply to everybody, but there's probably a nugget for everybody to pick up somewhere.
Well, I think this report is an ideal opportunity for us to share that good practice. A lot of discussions are going on, and I think one of the really strong features that's come out of this is that collaboration that Chris was talking about between different providers in areas to try and make sure that patients in a local population are getting the care they need as priority. And when that's being done well, it's having quite a big impact. But I think there's real opportunity for us to use this report as a way of sharing best practice, Peter.
Chris?
I agree with all of that, and I think it's important that we can share this with frontline staff and organisations. I think it's also important that we can share it with those who are responsible for the construction of the ICS and the model of performance management. And I think we're having some really good conversations with NHS England about how we use some of what we're learning from this to build an understanding of what good might look like in an ICS. So in our own regulatory oversight, but also in the oversight that NHS England and others will offer, I think it's important we look to these outcome measures of improvement in an area. So I think there's a number of channels for this. There's some direct conversations that I know Ted and colleagues will have with system representatives at a provider level and a frontline level. And I think it's up to us to continue the conversation with DHSC and NHS England about how this forms part of the oversight framework for ICSs moving forward.
Great, thank you. Robert?
Thank you. Very welcome report, and it seems to be one of the messages that comes out of it is the vital need for appropriate communication with and from patients. And in that regard, 2 weeks ago, Healthwatch England put on its website some advice to patients about what to expect by way of good communication. And I commend it. It's only about, I won't read it, but it's about 5 different points. And we've asked for feedback from people, good and bad, about how they experience it. But what I would suggest is that that we consider is to ask actually providers what are they doing about finding out what the expectations of their patients are, because it's all very well the system talking to itself about the need for improving waiting lists, but actually you've got to engage with the patients about this, and good communication is clearly the key.
Just to say, Rob, I absolutely agree. Ted's talked very eloquently before about how we view well-led in an organisation, and I think the engagement with service users between an organisation, how well they understand the service users, is a key part of how an organisation determines it's well-led. Also to say, if you look at the driving improvement work, all the organisations that we've seen improve from inadequate or requires improvement to good or outstanding, fundamental to that was how they engage their frontline staff and indeed people using services, and without that we don't see improvement happening in organisations.
Thank you. Stephen, and then we'll come to you, Mark. Stephen.
Thanks, Peter. Ted, I'd be interested to know more. I think if I heard you right, you were using the phraseology of we need a new model. Now, it's one thing to say, you know, we need to understand the best of what is happening within the existing system and encourage ICSs and others to use it. Is that what is meant by a new model, or is it actually something more fundamental, that this system is not what we need and we need something different?
I think the model that we have at the moment, where hospitals try and provide acute care, urgency emergency care, and planned care within the same footprint, is increasingly a problem. If we can change the model of care around urgency emergency care, so we're not funneling all urgent emergency care into hospitals, and we're actually caring for patients in a better environment, giving them better care in a better environment, and hospitals can focus purely on those patients that hospitals need to look after, then there may be space for that model to continue with urgent emergency care and planned care in the same footprint. I think the Royal College of Surgeons has suggested that we should create more elective centres that do no urgent emergency care and just focus on elective work. And that may be one model. I don't think we know the answer to this, but what we should say is that every winter, and remember the waiting list was going up before COVID. COVID has exacerbated a pre-existing problem. Every winter the surges in urgent emergency care were, if you like, ratcheting up the waiting list for planned care. And what we don't want to do coming out of COVID, we've got to solve the immediate problem, but we actually want a more sustainable model that protects urgent emergency care, makes that safe and effective, but also creates an environment in which elective care can be done in a timely manner as well. And I think that's a real challenge to thinking about how we operate. And I think that integrated care systems can do that because they're looking at care across a whole population. But they need to think differently. And I think there are great lessons coming out of this work and all the work around COVID to how we can drive forward care in a way that protects every element of care and doesn't prioritise one over another to the detriment of some sections of the population.
I think, Stephen, this is a huge subject. We could devote days to it. But Rosie, let me just bring you in on it.
Well, just to add to what Ted's saying, I agree we need a new model of care, and I think we need a much more proactive model of care rather than a reactive model of care that meets people's needs in the most appropriate place. And far too often we're seeing people end up in hospitals because they're not getting their needs met at an earlier stage in the pathway. And so I think we do need a new model of care. And what we're seeing across the country is some fantastic innovations that systems are trying to meet the needs of their population. What we need to see is those innovations rapidly scaled so that we can actually get those new models of care embedded that will actually help support people getting the right care in the right place at the right time and support the pressures on the system that we're seeing at the moment. I think we need a massive acceleration in that.
Stephen, did you want to come back?
Could I just, to understand, so who needs to own that as a problem or a challenge? Because you're both saying very, very clearly and compellingly, you know, we know something about how this needs to work, but it needs to be scaled and it needs to be replicated. Who should own that? Because if we just put it out into the ether, the chance of anything happening will not be great. Do we own that?
Chris has got his hand up,
think,
probably not to volunteer that he owns it, but Chris.
I think this
Yeah, absolutely. So the oversight model we have, or the model that we have, is a function of how we've constructed it. And I say we in its broadest sense, not the CQC, but the health and care system. So how we pay people for services, how we govern them, how we the targets by which we set for which that is a function, that is the model we've got today. We've got the model that works to the things that we've set out. So in order to change the model, we have to change the function of how people have a common purpose for a local area, are paid to work together rather than deliver services in isolation, and how the oversight it reflects on all the organisations and not individual ones. I hope that some of the work we'll do with the oversight for local authorities and ICSs will give some ability for us to have some influence over that. But I think there is a really fundamental element about how we encourage services and those who have oversight for them to think differently about that. And I think there will be a number of conversations that we have as ICSs are formed. And as I said earlier, part of what we want to use this information for is to guide the development of ICSs so that we can have the right oversight framework, and with the right oversight framework and the right payment framework, I think we'll have the model that we need.
Chris, you said we quite a lot of times in that. Just to be absolutely clear, the we is not us.
No. So when I speak of we, there is CQC are obviously an important part of this, but there are the DHSE, NHS England, all those that have an oversight responsibility for health and care need to come together in this regard. I think we have a part to play, but we are only a part of that jigsaw, and we need to make sure. So I think we can guide others, and I think the benefit of using our independent voice is to stimulate debate to encourage the right action to take place.
Rosie.
Yeah, I just also want to add that I think the ICSs have a huge part to play in this. I think that's where they understand their population needs, and they need to be driving these new models of care. But also I think we need to really engage with the public, and we need to work out how we can encourage the public to have a part to play in this as well in their local communities. We need to talk to all parts of the system. These problems these challenges are very big that we're facing at the moment, and we need all parts of the system to work together, and that includes health and social care, but it also includes the voluntary sector, people like local faith groups, working in conjunction, and broader aspects of the sectors of the systems like education, like housing, looking at those wider determinants of health, and then we'll start to make some difference in terms of people outcomes.
Good, thank you. Useful debate. Thanks, Stephen. Mark.
Thanks, Chairman. Chris, very good report. Thanks very much indeed. Page 7, when you're talking about managing staff who, have already burnt out through the pressures that they've been under, I just wonder if this report is not an opportunity to also demonstrate some best practice by organisations in managing this. I happen to be talking to the HR director of a foundation trust this week, and we were talking about this, and he mentioned some of the work they were doing in terms of walkarounds by senior management to demonstrate support, self-help guides in terms of managing stress, anxiety, had a phrase that they used around kind managers making a difference, had a poster program for especially those staff who don't see the support system, so night shift staff who particularly haven't, in this organisation, had an issue around hot meals on night shift. And so they had a campaign around You Said We Did to demonstrate support, and actually the appointment of a health and wellbeing advisor. These are just ideas, but I'm sure there's a lot of really good practice that we could help to disseminate across the sector.
Absolutely, Queen. It's fundamental to how we cope both in the short term and the long term. I think one of the things that was striking to me in the conversations that we had was that the most important, one of the early most important things was to say it's okay not to be okay as a frontline member of staff, and actually giving people the permission to be not okay and provide the right support. And then, as you say, some of the very obvious things like the one particularly the meals in the evenings. Typically vending machines are the only course of meals for people out of hours, but deliberately going out of your way to make sure if you're going to provide a 7-day service and a 24-hour service, that it isn't just for service users, it's also for colleagues as well. And I think so. Some of those, I think, we want to do some work with NHS providers and NHS Fed around how we share that best practice. And I think there'll be best practice from other sectors as well. So Rosa mentioned primary care, and I think there's some really good examples of how you encourage people who have to work remotely or by themselves to provide the right support for how they can form some virtual peer networks. So there's much good practice out there that we have to help in how it's shared.
Yeah, Chris, I just wanted to just follow up on the appointment of the Health and Wellbeing Advisor. What was really interesting that this HR director was telling me was that person focused on those employees who are living on their own. So they come in, they work a 10-hour shift, and it's really, really hard work on acute wards, and go home and they're on their own. So worked a lot there to support them and to engage them to find friends and social activities outside of work. And I just thought that was a really practical example of engaging with staff and helping them through this very difficult period.
Thanks, Mark. Sally.
Yeah, thanks, Peter. Thanks, Chris. Really insightful report as usual. I'm always conscious that we have some really good examples of best practice that we outline in our reports. And I suppose my question is, how much influence do we have to both tell other organisations about those and to try through our inspections to make sure that people are aware and they can start to implement them? Because for all my years in health and social care, it's very difficult to try and spread that best practice, isn't it? And for people in other organisations who haven't originated those ideas to take them on board. So I think our report is great, but what can we do to be able to spread those examples of best practice?
I think you're right. One of the things about adoption of best practice is if it isn't created in the organisation, it's often say, well, we're a bit different to every other organisation. We've begun some really good conversations with NHS Confederation, NHS providers in the context of this report about how we share some of that really practical guidance about how we move towards winter. And we published a guide for clinicians early in the year about how to cope with urgent emergency care. And I think we'll try to redress this in a way that's practical for people who have to manage people in an NHS environment, and we'll probably do that through NHS Confed, NHS providers and NHS England, because it isn't just about the regulator talking, it's also about their support organisations talking about what they do. So there's a number of opportunities. There are roadshows that NHS England are taken as we go into winter, and I think being able to tell some of these stories in those conversations will help. But it's a constant. It requires constant attention to make sure people are learning from what others are doing. And actually, what you do through that process, you pull out more good practice, because people say, well, actually, I've done that, but I've also done this. And I think I never see these reports as a completed article. They are really they're sort of fishing for other good practice, other good ideas, and we'll continue to do that and share that. And on a separate note, Mark, we talked earlier on about the use of the website and the development of the website. I want the website to be a home for good practice. So when people think about a particular issue, they can come to us and we can share our understanding about good practice that's relevant and timely. So working through other organisations and then developing our own content, I think will be key parts of that.
Ian.
Just to build on that point, I think we also promote these reports internally, because I think what we do know is there's a powerful degree of sort of micro coaching that goes on as inspectors talk about specific issues on inspection, And some of that's about their own experience, but some of it's about taking lessons learned. I think of the Smiling Matters report that Kate and her team did, had a profound effect on oral health in care homes. And that was about individual inspectors just promoting a piece of work that we've done. And I think this is another good example of that. And Ted mentioned earlier on the work that has been done with urgent and emergency care. And again, that sort of, it feels like a bit hand-to-hand combat in some respects, but to get these messages out there. But it's something that we do internally and externally. Thanks, Peter.
Thank you. Dora.
It's more of a question for Chris. I mean, at the moment, I guess the report is based on the data that we know now, so it's an as-is. But if you look at the macro environment where we're seeing people leave adult social care, and I think Kate said, opportunities in tourism, we're seeing definitely sort of early retirement happening in sort of the world of GPs. And we're also seeing, more investment or, government pumping more money into services. Does it take into account, as well as the as-is, the sort of to be based on what's happening in more of a macro sense?
So this report is designed just to share some of the best practice from a variety of environments. Those 73 trusts will work in a variety of environments that have all the things that you've described. So people, adult social care, handing back contracts, GPs retiring, and there's in a sense a collection of things that they are doing is to help manage and mitigate some of those issues. I do think there is a macro. This is partly what SATA cares about. There is a macro conversation about how do you provide the right environment for services to function well together. And some of that, as I go back to before, I said about it's about having the money and the incentives in the right place at a macro level to encourage the right conversations between organisations. And I think what we can do, we can show the advantage. This is an example of the advantage of how it works well together. I think we've also got to show when it doesn't work well together and what the consequences of it not working well together. But I think we've got to be mindful of what do we want the changes to be. And I go back to we talked to a couple of boards ago about the work that is being done to help understand how local areas are functioning today. So the ONS is doing some work on a health index, which gives us an understanding of how individual areas are working. And I think it's important that we can challenge ICS and local authority groups to talk about where they are today and how collectively they work on where they need to be in a year's time. And the more we can give that sense of local ownership to the problems, I think there is a better opportunity to drive the right change. So at a macro level, I think we have to describe the problems and the opportunities in the same way, but I think we have to focus on what we think the ultimate goal should be.
Great, Chris. It's a really good report. It's prompted a really good discussion around this table, and I hope it prompts discussions around the system, because it's really, really excellent. So thanks. Let's move on. Jill, you're extremely welcome. Nice to see you. And you're going to talk to us about the Pulse survey.
I am indeed. I'm delighted to be here. So you recall that this is the latest in a series of Pulse surveys. We agreed a couple of years ago nearly that we would go to a full survey every 2 years and then supplement that with quarterly Pulse surveys. So this is the latest. We're bringing the responses to you for transparency purposes, as we always do. And you'll notice that in this particular Pulse survey, we've done our kind of focus on mental health and well-being, which allows us to do some follow-up work on the Mind survey that we undertook earlier in the calendar year, which resulted in us, I'm delighted to say, being awarded a silver status by Mind, our first foray into the Mind wellbeing survey, and so I think that's a great achievement for us as an organisation. So, as I said, in this survey, we also asked the standard questions that we've been tracking every quarter in our Pulse surveys around some change questions, but also the question about recommending CQC as a good place to work, which allows us to, as I say, track our performance, whether that's up and down or steady over a number of iterations. We've had a healthy response rate of 74%. It kicked off at the beginning of, I would say, the summer holiday period for schools, and so it's reasonable to assume that some people were off for the period of the survey, but we didn't want to delay it any further. The feedback on the resources available to support mental health and wellbeing were generally really positive. I'm confident that means that we've got the right range of support and tools in place for our colleagues, and that our colleagues are also clear about what is available to them and how to access it. Feedback about support by line managers and colleagues remains really high. So our support from line managers high at 82% positive. That's fantastic response for an organisation of our size. And also the report that people feel and get from their own colleagues and their own teams it remains quite high as well. So this, I think, gives us a sort of a real sense of the support that is on offer to colleagues through what has been probably quite a bumpy period over the last 18 months. And the question when we are asking at macro level about whether we as an organisation support health and wellbeing of our staff has increased by 5 percentage points since the last time we asked that question in November 19, which again I think is a really solid improvement. There are responses about workload questions. They remain on a par with where we were in 2019. So around half, 49%, agreeing positively that they have a manageable workload. The free text comments that supported this survey indicate that that workload is an issue for some colleagues, but actually there are a whole range of other issues at play, and so we need to recognise that people bring their whole self to work, and therefore they're sort of where they are in terms of their mental health and well-being is beyond the realms of CQC, and actually, you know, we need to play this in totality, particularly when we're looking at the results locally. I'll just kind of focus briefly on the scores for the two change-specific questions that we've included. They've decreased slightly from where they were in the last time we asked the questions, so they're slightly less positive about our strategic direction and feeling informed about changes that are happening as part of transformation. Than when we asked the question in October 2020 and in March 2021. So at the moment we've got 43% positive answer around the strategic direction question. This is down 13 percentage points from March 2021 when it really did peak. We'd just done a huge amount of work around our strategy at that point, and communicating that with within the organisation. Then there were kind of the questions around there's a slightly higher figure of 56% agreeing that they feel informed about changes that are happening as a consequence of the transformation programme. When we compare this figure with previous pulse surveys, it's slightly down on where we were both in March and October. But as we move into implementation of transformation, we anticipate that these scores will probably go up and down a bit. I think it's entirely normal that would happen in an organisation, particularly as we sort of move closer to the changes and the implementation of them. We want to minimise this, obviously, as far as possible, and so we'll be ramping up our engagement activities in the coming weeks and months as we move through into implementation. And we'll be providing regular opportunities for two-way engagement, more regular. We've had a fair amount of engagement probably since this survey was live, actually. So a huge amount of activity in terms of consulting staff, engaging staff throughout the summer period, which I'm hoping will kind of bear fruit in the autumn time when we move to a full survey. So I think I'll pause there. It would be really, really important, I think, to hold in our minds that actually these survey results indicate to us that the role of leaders and managers in enabling well-being and good mental health in the organisation are really important. I think we're doing good things there. There's always room for improvement. And we also need to focus and maintain our focus on our narrative assigned to transformation. So we'll be using the data from this survey to target either specific areas in the organisation where we've got hotspots and cold spots, or particularly where certain groups of colleagues are actually answering less positively, so that we can understand where we can best focus our attention in the next period. I'll pause there.
Thanks, Jill. I think these are really, really useful. And as you've just said, they give us as an organisation the ability to respond to people's concerns and needs. I think it's really good we continue this programme. So thank you for doing it, and thanks to the team behind it. Questions or comments? Kate?
Thanks, Peter. So if I could just add a comment around workloads. So in adult social care, the question about I have a manageable workload is 31%, so lower than the overall position. If I reflect on inspectors' workloads over the last 18 months, so in adult social care, 65% of our inspections are risk-based. And when we go out to the services that we're concerned about, we're taking enforcement action in 26% of occasions, which is massive. It's massive in terms of the pressure and the burden that puts on inspectors. It also has knock-on impact to people like Rebecca's service of legal colleagues, engagement colleagues who are helping us share the information in a timely way with the public as well. So there is a huge amount of pressure on inspectors within ASC and across the organisation. When I talk to them and when we look at the comments in the Pulse survey, it talks about not having a balance. So inspectors generally at the moment aren't seeing good. They used to love having a portfolio that was mixed, where they saw the outstanding service, they had a load of good services, and they had some services they were worried about and taking action on. So in my bit of the business, we're looking at things like how we redistribute work around the country, and we're also looking at when vacancies arise, where we might need to move them to other bits of the business so that we are making sure we've got the right staff in the right places. And then finally, very briefly on the change bit, I think there is an eagerness of, okay, great, what's it going to look like? And I think my view is, we could tell, you could have a small group of the exec members or the top leaders in the organisation sit in a closed room and design it. We could do that, but we don't think that's the right thing to do. We think the right thing to do is to have really good, extensive engagement, because our frontline staff across all different bits of the business, have got really great opinions on what should networks look like, what should hubs look like. So I note the frustration that might be emerging and reflecting in this Pulse survey. And what I'd say is that frustration is there because we are looking to design our organisation with our, with all parts of our business who knows what it should look like and will help us come up with a much better product. So I recognise it. I still remain absolutely committed that we are taking the right approach. And I think engagement in the Connect and Explore, and we've had staff from all different bits of our business come along and help us shape our thinking, is testament to the fact we've got this approach right. But I think it's just noting the ongoing anxiety that creates, because we're not doing this quickly. We're trying to do this meaningfully. Thank you.
Thanks, Peter. And can I just pick up on the point that Jill made about the free text comments? There's extensive free text comments that underpin this survey, and one of the things that was quite striking was this point that Jill made about people bringing their whole selves to work. There was the reasons that people's personal well-being was problematic in some cases, was issues of divorce, family breakup, bereavements, and a whole range of things. And so that does link into this issue of manageable workload. What was also striking was a reasonable number of people were also suggesting that as an employer, that's none of our business, and they didn't want support. They didn't see as an employer that we should be supporting them in that space. They felt that was a private matter for them to support. And then other people were talking about wanting support in a range of different places, which were things like support around financial advice, support around relationship advice, and a whole range of other things, which are kind of, in many respects, way beyond what you would normally expect to see from an employer. And I think it just does talk to this whole thing of the last 18 months has rewritten the fundamental relationship between an employer and the people that work for them, and different people have wildly different expectations around what that might look like, and then that manifests itself in issues of well-being. And we've seen that earlier on in the meeting around sickness absence and the conversation we had there about people's mental health. So I think probably in common with many employers, I think trying to work our way through where is the place we want to position ourselves as an employer is really important. How much support can we genuinely give people? And I think the support we have put on the table has been well regarded, and some of that's straightforward, like access to the Headspace app and the quality of management and so forth. But I think we are very open to what else can we sensibly do, as opposed to just putting lots of things on the table. But and just to reiterate to Kate's point as well around this idea of trying to co-design our future with our teams is a choice, and we've made a choice to do that, and not everyone agrees with that choice. And I think that reflects in part in this survey. But I do see a positive overall trend in terms of where we were in 2019, where we are now, and people still do want to come and work for us, and we are still recruiting people, despite the fact that we're doing a number of things around fixed term contracts and so forth, which in some respects would make us less attractive as an employer. Thanks, Peter.
So I think, Kate, one of the things you're saying really resonates with me. If all you see is the struggling providers, it is quite depressing. Pre the pandemic, I used to spend roughly a day a week visiting a provider, and I'd come back really excited and energized when I went to somewhere that was really outstanding, and come back quite depressed when I went to somewhere that was at the other end of the spectrum. So if all you're seeing is the less good, it must actually be quite soul-destroying after a while. So I really get that point. Anybody want to... right, Stephen and then Robert.
Just wondered if there are kind of a few dots that might link together, sort of starting with about half of the organisation staff feel their workload is uncomfortably heavy. Sickness absence rates going up. A big change agenda coming down the track without yet being able to describe exactly what will it mean for me. And that's a kind of compounding of pressures on people. And I absolutely buy Kate's approach, that the right thing to do is kind of hold our nerve, take people with us, indeed give them a strongly engaged place in creating that future. But in real time, we've also got a set of colleagues who are feeling under immense stress. Kind of how does all of that fit together? Can we at least give them a clear sort of timeline for when they will see light at the end of the tunnel? I'm sure that's part of the whole presentation, but I'm just sort of a bit nervous of a workload already feeling under enormous workload pressures, a sort of rather indistinct sense that it's going to get worse before it gets better. How do you keep all of that moving, I suppose?
Yeah.
I don't think there's a simple answer to that. I mean, I think what we're doing around communication of the change program, we're talking about broad timelines. We're talking about when we'll make decisions. We're talking about that sort of thing. We're trying to give people a degree of certainty. But I think we do need to recognise that the nature of the work that we're doing is we are working in amongst a health and care system which is under the most pressure it's been in a generation, and I, to some extent that's quite difficult to fix, and so I think we will continue to look for ways to inform and help our teams understand what's going on. But I think some people genuinely want an answer and they want it now, and we're simply not going to give it to them. So there's something about a fundamental difference of opinion, if you will, in terms of how to pursue a change program. But that said, if you look at the change program as a whole, our change program is not change for change's sake. It is to address a number of these big fundamental issues around workload, around consistency, and so forth that have been long-standing issues. And so these are big problems to solve and require big, audacious approaches to it, and we'd like to co-design that with our people. And some people really embrace that, and some people don't.
So Ted and then Chris, and I haven't forgotten you, Robert, but we'll just sort of carry on this.
Just to say that I agree, Stephen. The number of colleagues who are concerned about their workload is something we need to take on board, because it is important that we give people a manageable workload in their working lives. The figures we're getting at the moment for this pulse survey are much better than they were pre-pandemic in the last people survey. So you know, we need to be clear that the trend is improving. It's slightly less than, you know, the last survey we did, which, remember, was a time when we weren't inspecting very much. We discussed earlier on in this meeting the increasing number of inspections, the increasing whistleblowing and concerns our inspectors are managing, and this all adds up to extra workload for them. So I think the real message that comes out of this is we need to find ways of smarter working. We need to find ways of being a more effective, efficient regulator, which of course takes us back to the transformation programme. And I suppose there's probably a message, you know, perhaps we need to remind colleagues that the transformation programme is about helping them and their working lives. Perhaps that message isn't strong enough, because I think if you see that connection, it's really important. And what we've done during the pandemic in terms of going to risk-based inspection has had the downside that our inspectors tend to see the poorer services rather than the better services, but it has given them a much more streamlined inspection approach. And I think that is the benefit, and maybe why our current figures are better than they were pre-pandemic. But in order to get to where we want to be, I think we need to see the transformation through. I think that's the message here.
Chris?
As you said, there aren't any simple answers to this. I think there is something, to Ted's point, about the strategy that we published this year is partly a function of what people wanted to see different about the organisation. So it didn't come out of a conversation that we had, as you know, at board or ET one day. It came from lots of engagement. So there is something about reminding people of where we are today and why it's important to change, and in some cases why the status quo isn't tenable. So it probably isn't tenable to continue to write 30-page reports that people half read and where no action is taken, where people are cross that they have to repeat information in different aspects of it. So how do you create a better view of quality? It does require change. We're talking at the Way Day that we had as a senior leadership group about moving from a rules-based system to a tools-based system. So we've created a system which people, in some degree, follow a set of rules to deliver an outcome of a regulatory report. And actually, what you want to do is to empower people to create a view of their patch. What do they think of their patch? But that is a cultural change, and there are practical changes and there are cultural changes. I think, as always with these things, advocacy from people like me, i.e. people who are talking about these issues, is really, really important. And within the organisation, there are people who are really strong advocates for what the change. They understand it, they understand the benefits of it. So helping them to create an environment where people can see the benefits of the change in the micro for them, for their job now, for their job in the next 6 months is critical. And in some senses, there will always be improvements that we want to make, but getting that sense of what will be different for me in a few months' time, how will it help me, is important. Interestingly, Ted's work on the changes to some of the inspection reports that we've done in urgent emergency care is a really good example of that. I think people can see the genuine benefit of those services, the inspections that help those services work differently. So I think we can use that as in part to help sell a message about how things can be different in the future.
Rosie?
I just want to add to Kate's point that our inspectors have very, very difficult jobs, and never more so than at the moment. And I just want to add the point that they're actually having to deal with quite distressing situations at the moment where they're phoning providers, and anecdotally they're getting lots of phoning providers to have a conversation about how things are going, and providers are using that as an opportunity to talk about all of the difficulties they're experiencing, and sometimes they're having to deal with very distressed providers. And this isn't just in the struggling providers or the inadequate providers that we're seeing. This is in some of the good and outstanding providers as well. And so the emotional impact on that, on our inspectors as well, will be a factor in this. And so I just want to thank our inspectors for all they're doing at the moment in these very, very difficult times.
Thank you. And at last, Robert, we come to you.
Well, no, thank you. Well, firstly, actually, it builds on what is being said about the remarkable work our inspectors are doing. And I just make the comment, firstly, that depressing it may be, but they need to take home the value of what they do for the people whom they are serving. And that is, in many ways, doing that many times more over than they were before, if that's only going to the so-called bad places. But I can understand entirely the stress. And that brings me to the point I was originally going to make, which addresses Ian's very perceptive remarks about the combination that people have often between the problems they might have at home, which will have been building up during the pandemic, everyone knows that, and the stresses and strains at work. And just as much as people will bring to work with them the mental problems that are not mental problems, but the issues they may have at home, they take home the issues they're having at work. So it is actually quite difficult to separate the two. And working out what it is as a good employer one can do to assist but also mind one's own business is extraordinarily difficult. But I imagine that one thing that is probably necessary is a degree of clarity about how far one can go. And I appreciate that might need to be varied on an individual basis, but also to have a set of tools about referring people who need support to where they can get support. And I say that because and you weren't doing this at all, but we certainly can't, it seems to me, give the false impression that we don't care, because we need to be a caring employer. We need to be an exemplar in this field, because everything that we are seeing amongst our staff must be amplified many times over within the health service. And I think together we need to struggle towards a way in which to provide people with a safe space to share these issues, at the least, not fearing that if they mention they've got a problem at home, that's a career-limiting issue, because I think there probably are some places where that would be the case. We certainly shouldn't be in that category, and I know you don't intend that.
Thank you. Kirsty, you wanted to come in.
Yeah, thank you, Peter. So I just wanted to say, I think when I look across the scores, there is quite a lot of variation, particularly in different teams, and I think it's sometimes quite easy to sort of take the negative view and look at that across the piece. But there are some areas, and there's certainly a few in my area, where the teams are working really, really hard. They're up to their eyes with transformation, short of resources and things, but the scores aren't too bad. And I think there are other areas in operations where that is also the case. And I think there's some really good learning that we can take from that in terms of where we've got those sort of really sort of hotspots in terms of positivity, that we should be looking to look at what the best practice is there, and then share that around across the organisation, particularly in those teams where the scores are slightly lower. So it is a bit of a mixed bag, and I think I just wanted to really make that point clear.
Thanks, Kirsty. I'm going to come to Sally, and then unless anybody's got anything really, really burning to add, we'll move on. But Sally.
Thank you, Peter, and thank you for the report. I share a lot of the concerns that Stephen and Robert have raised, and I won't reiterate them. But sometimes, when Jill talks about a 43% positive score, for me that's a 57% negative score. And I think we really need to look at the variation that Kirsty described across the organisation to understand where people don't feel supported or don't support the future direction of the organisation or all of those things. I think the pressure across health and care generally is huge. Every organisation that I come across says that their workload is unmanageable, and that isn't going to go away for us. We need to recognise that. But I do know of organisations where the percentage of staff who feel they are supported is a lot higher. And I think we need to recognise the workload and the great efforts that all our inspectors and our support services are putting in, but think quite clearly about the support we offer. And that's back to Jill's point, I think, about how you do this through management, through middle management and line management, and perhaps that's something we need to think about. Just in terms of the future model that Kate and Ted and Rosie talked about before, and how depressing it is sometimes to only go into services that aren't good. If we are going to we need to think about this for our regulatory model, because if we're going to have a risk-based, effective model of regulation in the future, it's likely that although we need to recognise good practice, we are going to be more involved with providers who aren't good. And that will have an impact, won't it, on our future ways of working. And perhaps there's something we can think about how to encourage staff when they will be going to places that don't fill them with enthusiasm for more of the time.
So lots of people bursting to come in, but I want to bring in Paul, and then we're going to go to you, Kate. And I know you absolutely need to respond to what's just been said, but we'll give you the last word. Paul.
Just to give an example, what happened in registration about 2 years ago, that the workload was very, very stressful because we were dealing with unregistered providers, then we did a partnership, then we did complex stuff, and it wasn't manageable. But since the registration team designed something, now we've got a unregistered providers team, and we've got a dentistry team that focus on those complex work. We can deal with other works as well, but any other work they can pass on. And we feel in registration our workload is more manageable because we're not doing 5 different things in one day, and that's the stressful thing. We're dealing with dentist, then GP, then hospital, then independent ambulance. But generally, I mean, there's still some teething issues, but generally the well-being in registration has improved because we're not doing so many different juggling things. So that's, I only speak to registration, but I'm just saying it's a positive step from that.
Thank you, Paul. Kate.
Just super quick. So it's really important we don't lose looking at and celebrating good and outstanding. If we think about our strategy, we want to have a really strong role in improvement. Well, how do we know how services should improve and what the culture should be and what the components should be of an outstanding service without getting out there and seeing it? So I am really hopeful that we can start seeing a bit more of that balance. So we need to be risk-based, we need to be responsible, we need to be flexible, but we also need to see the good and the outstanding so that we can talk about it and shine a spotlight on it and say, you know, look at what they're doing over there because it's making a difference for people.
Ted, go on.
Well, I just wanted to say, I mentioned earlier on that we're about to publish a report on the Trust that, despite the pandemic, has improved dramatically. And that was a very uplifting episode for our inspection team that have gone in and done that inspection over the summer. And, you know, I think, you know, when that report comes out, many congratulations for the Trust and all the staff who've been working through the pandemic. But we just should remember that the impact of regulation has driven that improvement. And, you know, and our staff have got a lot to be proud of. And I think we need to have those opportunities to motivate our staff because they can see the improvement they're driving.
Thanks, Ted. Go on, Jill. Last word to you.
Thank you. So some really helpful comments and reflections, and I think shows the complexity of what sits behind a data set, because actually this is about people and how they are feeling, how they experience work. But just on one final point, Sally, when you talk about kind of the flip side of 43% positive being 57% negative, it's actually, there's a neutral bunch in the middle, and in that particular question it's quite a reasonably sized 36% of those who are kind of not negative or positive yet. So I see those as the ones who are to be persuaded and the people that we particularly need to work with. So that doesn't necessarily mean that everything is negative if it's not positive. Thanks.
Right, really good debate. Thank you very much. And Jill, thanks for all the work that's gone into this. Rosie, we're going to move on to the Defence Medical Services review. I see you brought reinforcements to support you.
I have brought reinforcements. Can I introduce Andy Ford, who's Head of Inspection in PMS, and Tanya Biles-Simpson, who's our Inspection Manager, who leads the DMS work. And just to open with a few words of introduction from myself, this report presented is culmination of 4 years of work of inspecting Defence Medical Services facilities across the UK. And it demonstrates the state of quality across DMS and also the significant improvements that have been made across the services. This is a contracted service. The aim would have been to complete all of our inspections by April of this year. But unfortunately with COVID, the programme was suspended as the military personnel were redeployed. So our inspection programme had to stop. We've just negotiated a further 2-year SLA to complete the programme and develop their approach to assurance and regulation for the future. It's a highly successful programme led by Andy and Tanya and a very small team who do brilliant things for the size of their team. But they bring in expertise across the organisation from general practice, oral health, hospitals, mental health and rehabilitation. I just also want to say thank you very much to Gary Ford, who also had a leadership role and was very involved in this programme, our Head of Inspection, prior to Andy. Finally, I just want to say we've got really, really good strategic relationships with the DMS personnel, and the contract makes a really positive contribution to ensuring services experienced by UK service personnel are safe, effective and well led. So thank you. I hope you've enjoyed the report. Tanya or Andy, I don't know if there's anything, I'm assuming people have read the report. I don't know if there's anything you want to just add to that.
Thanks, Rosie. So, hello, everybody, and thank you for allowing us the opportunity of coming and exposing this, what is quite a vital piece of work, actually, to you as the board. As a head of inspection, there seems to be quite a stark difference between my work with regulation of primary medical services in London to that experience that we experienced in the military. Quite clearly, medical services in the military have got a massive span of operations pretty much throughout the whole world. And whilst there is quite a significant proportion in the UK, those services quite clearly are on board all military assets as they spread throughout the globe. And the ability to drive change and improvement within all of those services, whether they be aboard a nuclear submarine, an aircraft carrier, or indeed on a large aircraft base within the UK, is a real tribute to Tanya and the team, who's worked really hard. And I have the glorious opportunity of engaging with some inspirational characters and senior commanders within the military, which all tell a very positive story of not only the work that Tanya and her team do, but work from Hospitals Director, Ted's team from mental health, and we've even started to tread fairly carefully into the realms of looking at the well-led aspect of how the military command military services, which is testimony to the negotiation skills of Tanya and Ted's team, I believe, really, because it is a slightly difficult subject in a very hierarchical society that they work in. But that's work for us for the future. But I won't take up too much of your time. Obviously, invite questions at the end. But if I could just hand over to Tanya, who could fill in some of the operational details, that would be great. Thank you.
Great, thank you. Tanya.
Thanks, Andy. So across the 4 years to date, we've inspected 90 medical centres, with over half of these being rated as either inadequate or requires improvement in safety on a first inspection. Follow-up work has therefore been key in ensuring that improvements have been delivered, and I'm glad to say that after 2, 3 or even 4 inspections, those improvements have been largely delivered. We've inspected 40 dental centres to date, and as with the medical centres, the most non-compliance relates to safety and specifically poorly designed and under-maintained buildings. And once again, over the 4 years, most of these concerns have been addressed. We've inspected 10 regional rehabilitation units and have judged all of these to be good overall in terms of the quality of care. With regard to mental health, we've inspected 9 facilities and have rated across the whole spectrum, including 1 inadequate overall, 1 outstanding, and the rest being in the middle. We've undertaken follow-up work, and we continue to do so to ensure that improvements have been delivered across mental health. During year 4, we were unable to inspect on site as a result of COVID, and so we took the opportunity to work with DMSR to develop an interim approach to gain assurance. This allowed us to pilot an entirely virtual approach led and owned by DMSR. There is potential for us to use this approach going forward and even beyond COVID for services that are geographically remote and hard to reach. Feedback from the military regulator is that CQC's contribution has been paramount in triggering key improvements across all of their clinical facilities. They have extended the service level agreement for an additional 2 years with a possible further extension of 1 year beyond that. Any questions?
One final thing, Peter, can I just say I'm very sorry, but I said Gary Ford, it's Gary Higgins. This cold is impacting on my brain and function, I think, so apologies.
We noticed the deliberate mistake, so don't worry. I was just going to say in response to what you just said at the end there, Tanya, that this is actually a huge tribute to the work that you have been doing, because unlike everybody else who has no choice but to be regulated by us, they do have a choice, and the fact that it's been renewed for a further 2 years, I think is a real testament to the work that you've all been doing. So thank you very much for that. Robert.
Well, firstly, it doesn't seem to me you've been inspecting HMS Vigil recently, but probably you don't want to go down there. It's a fantastic report, and it's so great to see what an impact there's been. But the question I have was whether there's anything for the wider inspectorate or the wider health Service to learn from the work that is done in Defence Medical Services, particularly in relation to the response you appear to get to unfavourable reports and what looks like a pretty rapid turnaround. And in that context, I was particularly interested in what's said there about the Defence Safety Panel, is it called? The SRP, Safety Review Panels, which is not something I've heard of in the wider health service, and I just wonder whether that's a key to improvement that we ought to think about more.
Thanks for the question. Let me reflect on it in two ways, really. I think there's at the moment I have the opportunity of looking after not only London and primary medical services, but both North regions as colleagues are away on holiday. And actually there's quite a stark difference in the ability to drive change in those two areas, let alone the difference between those areas and the military services. And I think basically it falls within two camps, really. I think you've got the military have the advantage over the NHS in some ways that they can just tell people to do things to support each other. So if there's any organisational reluctance to help each other, then that's easily overcomable within that hierarchy. But I also think there's their ability to drive change through being able to put much more enhanced support into a failing service is markedly above anything that the NHS is able to deploy, certainly within primary medical services. General practice is a prime example of that. You're able, as soon as there is a failing service, they're able to respond very quickly and very promptly with the absolute type of service they need to do to get better. So I think those are the two things. In terms of the quality review panel, I'm certainly no expert on that, so I'd like to defer that to Tanya.
Yeah, sure. So you'll be aware that the Health and Social Care Act doesn't apply, and we are at the invitation of DMSR. As part of that, we have been supporting over the past 4 years DMSR to set their own regulations, which are very much in tandem with the Health and Social Care Act. And the safety panels have been established as an enforcement route. So where we inspect and we have major concerns, we feed into that safety panel, and then DMSR can take enforcement action in line with their own regulations. So that's basically what that process is an enforcement action for improvement.
Can I just add, I think some of what the military are experts at are logistics and managing logistics, and I think that certainly the inspection I've been on in DMS, what impressed me was the kind of level of detail into systems and processes that really enabled that safe care that sometimes we don't see in some of the providers that are struggling, and the exactness of what was going on. And I think there is some learning, and I think we do need to think about how we share the learning between different sectors across all of the sectors. And Ted might want to comment as well, because his team clearly look at this as well. But I think we do need to reflect on how we share some of the learning more across the NHS and Defence.
Yes, well, I think Robert has pointed to a very important point, and that is that the military does respond to regulation in a very different way than lots of health services do. And I think there's a lot that we can learn, but also we can share with those health services about an effective response to regulation. Because I think the issues around the kind of leadership cultures that are defensive to regulation as opposed to those that are receptive and see it as an opportunity to drive learning and improvement, I think are very different. And we are trying to get the health services, the hospitals I regulate and other services, to respond in a much more learning and developmental way to regulation, rather than in this defensive way that they traditionally do. It's interesting that the point we're making about the military is actually a very similar point you'd make about a lot of independent health services who respond in a much more structured way to challenges from regulators. So I think it is an issue that we do need to share across services. And I think there's an opportunity. We're talking about well-led assessments of military. Well, that may be very interesting, but I think there's something we have to learn both as ourselves, but also to share with the other services we regulate from that.
Great. So, look, thank you very much indeed for the report, but more fundamentally, thank you very much indeed for the work that went into all of this. I think it's a really good example of of what we can do as an organisation. So just please pass on the thanks to everybody else that was involved. So we now move on and... Oh, sorry.
Sorry, Peter.
Oh, Andy, sorry.
Just to close, I think one thing it'd be remiss of me not to mention is that the support our military colleagues have provided to the NHS during the COVID crisis. They've experienced similar issues, identical issues to our colleagues, clinical colleagues working in the NHS, and they deployed a vast number of people to support the civilian services during the crisis, and they are now returning to the military with exactly the same stresses, strains, and workload issues as we have experienced. So I think it would be right for us to acknowledge that the support they've provided to the civilian services during the crisis.
Absolutely, thanks, Andy, for that. Right, so we will now move on, and Mark, we come to you. Can I just point out two things? One, that we've all read the papers, and two, that you're the only thing between us and lunch.
No pressure there, then. Thank you. The report is obviously in your pack. As a reminder, the Regulatory Governance Committee, our role is to provide assurance in relation to risks related to our regulatory program, and also importantly, to allow deeper dives into areas where our board agenda just couldn't accommodate the time that's required. There's an open invitation to all board members to attend, and I'm pleased to say that we have good regular attendance from across the board. So thank you to everyone for your participation. I took over as chair of the committee in February from Liz Sayce, and so the majority of what's in this report was delivered under Liz's leadership, and I think it would be helpful if Peter, you're happy with this, for Martin to reflect in the minutes our thanks, a record of thanks for and appreciation for Liz's leadership in relation to the committee. Reflecting the fact that we have a risk remit, we work closely with the Audit and Corporate Governance Committee, chaired by Sally. So Sally and I sit on each other's committees, which I think is helpful. We've had 7 formal meetings in the year reflected in the report, and another one yesterday, just for good measure. This year, I think what we've tried to do is reshape the forward planning for the meeting to focus on areas of effectiveness and efficiency as a regulator, to spend some time on lower attention areas, and to have a broader discussion and a deeper dive on some persistent problem areas that we see. We're very grateful for the considerable amount of work that the executive have put together in delivering some very comprehensive and thoughtful pieces for us. Areas that we have looked at include, the impact of the pandemic, and we've done deep dives for each directorate on lessons learned, our thematic review of DNA CPR, our public engagement strategy, lessons learned from our transitional monitoring approach, and our insights from our program of formal maturity inspections. And we've tried to do all of this with a forward lens. How is it going to inform and shape our future regulatory model? So, the report is in your pack, and I commend the report to you.
Thanks very much, Mark. Anybody want to say anything other than I absolutely agree we should thank Liz for the work that she did, and can I thank you for the work that you're now doing? It's really good.
Pleasure.
Great. So, unless there is any other business from the board, that is the end of the meeting as such, but we do have 2 questions from Robin Pike. I'll cover them both at the same time, and perhaps I'll ask Ted and Rosie to answer them both at the same time. So the first question is, how does CQC assess the quality of communication between hospitals or surgeries and their patients? And then the second question is, how does the CQC respond when coroners deliver verdicts that are critical of surgeries or hospitals? So I don't know which of you would like to respond first. Ladies first. Rosie. Oh, Rosie's given you the
Rosie's given me the floor.
Yes.
So Robin, as ever, thank you for your questions. These are two important areas. In terms of communication with patients, I mean, that is on many fronts. And we look at it through many lenses. Clearly, we take feedback from patients. And the quality of the communication with the hospital is really important. We also look at what the hospital has done to survey the views of patients, and we hear from bodies such as Health Watch about the interaction with patients. But of course, there are specific issues around how the hospital manages complaints from patients, the duty of candour, how it manages serious incidents and communicates with patients and involves them in the investigation of serious incidents. So there are many levels we look at the communication with patients. I suppose my overall conclusion is I would like to see hospitals much better at getting patient feedback. I think one of my sadness is that hospitals do tend to rely on the friends and family feedback, which I don't think is sufficient quality to give them the depth of understanding of patient feedback that they should be acquiring. And when we ask hospitals to demonstrate patient feedback in more detail, we often do not get a very strong response on that. And I think that's an area that they need to focus on. In terms of communication with coroners, coroners, if they are concerned about the care a patient has received, can issue a notice to a provider or any other body, I should say, to promote the prevention of future deaths. And these are issued by coroners, and coroners have been issuing them increasingly over recent years. It is very variable, and different coroners issue variable numbers of them. I'm always very grateful if coroners copy us into those reports, because it gives us an opportunity to take them up with hospitals directly. We do ask hospitals share them with us in any case. And what we're looking for is not the number of reports. We're looking for evidence that the hospital is learning from the report and is using the report to drive improvements in safety. And I think that is really very important, as we would for many safety incidents. It's important that hospitals are learning and driving improvements in safety. And that's what the response we expect to see from them in terms of the coroner's response. So I'll hand over to Rosie, if she wants to say anything from PMS's point of view.
Thank you very much. And very similar mechanisms in PMS. Thank you, Robin, for your question. And we work with the local patient participation groups of the surgeries. We look at the quality of communication on things like the practice website, and we hear feedback from people using services. We would like to get more feedback from people using services to inform how we assess that quality of communication. And particularly at the moment, I think that communication is vital, that practices and providers spend the time engaging well with their patients who use the services to talk about service changes and talk about how they're delivering their services and how people should access their services. I think the other thing to mention is I think there is a real opportunity as we start to look at systems in more detail about how we work with the public to look at the quality of communication from services together, because sometimes I think it's important that services work together to give effective communication to the members of the public about a whole range of issues. Our coroners, the coroner's question is the same as in hospitals, so thank you.
Great. Thank you, Ted. Thank you, Rosie. And that is the end. Thank you. So we've now got lunch.